Hi, my name is Azalea, and I'm going to be presenting the short bowel syndrome. Short bowel syndrome is a malabsorption disorder caused by decreased surface area on the inner lining of the intestines, which is usually attributed to the small intestine's extensive resection, increased bacteria, decreased intestinal motility, and congenital abnormalities, such as atracheus, blockage or obstruction of the intestines, or gastrochisis, which is intestines outside of the body. As you can see an example of that with this infant right here. Some of the findings in short bowel syndrome will be deficient electrolytes, fluids, and nutrients due to decreased surface area for absorption. Total nutrition replacement is necessary for optimal growth and development. Therapeutic management for short bowel syndrome includes surgical resection and sparing as much intestinal length as possible. Maintaining nutritional health for growth and development while intestines are adapting is imperative. Stimulating the intestines with enteral feedings and decreasing complications from therapy and disease-related issues of short bowel syndrome. Sometimes ostomy is indicated at the time of the surgical resection. Nutritional therapy for short bowel syndrome has 3 different phases. The primary phase introduces TPM via central line for total nutritional replacement. Right after surgical resection, the secondary phase is initiated as enteral continuous feeding through via J-tube or G-tube. As enteral feeding is increased, the TPN is decreased. As enteral feedings are tolerated, oral feeding should be reintroduced to prevent the child from losing interest in oral feedings and to maintain the mastication skills. The final phase occurs when intestinal adaptation has occurred and meets the child's growth and development needs. Complications of discontinuing the TPN. The child becomes at risk for a deficiency in trace minerals such as selenium, zinc, and iron, and the fat-soluble vitamins A, D, E, and K. This is related to decreased absorption in the surface area. Therefore, once TPN is discontinued, monitoring closely for these vitamins and minerals is important, as they will need to be supplemented via enteral feedings when deficiency is noted. Diarrhea is most likely to occur once TPN is stopped, associated with malabsorption of bile salts. Medication management for short bowel syndrome is cholestyramine is prescribed to decrease diarrhea. This may be given via enteral route. H2 blockers, PPIs, and octreotide are also used to stop secretions from the pancreas or from the stomach. Complications of long-term TPN are associated with central line infections. Sepsis can occur due to poor catheter care of the central line or due to bacteria from the gastrointestinal system entering the proximal site of the catheter. Education should be given to the parents on how to monitor for signs and symptoms of infection. They're going to want to monitor for any redness at the catheter site, any swelling, warmth, or coolness for infiltration. Also, increased bacteria in the GI can occur due to intestinal atrophy, allowing increased permeability for bacteria. Liver dysfunction And cholestasis are also some of the other complications that can occur with long-term use of TPN. The nurse should educate the parents to monitor for signs and symptoms of the liver dysfunction, such as yellowing of the skin and eyes, abdominal pain, abdominal distension, and light-colored stools. As you can see, this infant right here has yellowish tone to the skin as well as abdominal distension. Bacterial overgrowth normally occurs when there is an absence of the ileocecal valve or when stasis is present due to partial intestinal blockage or enlarged intestines with ineffective motility. Bacteria overgrowth can also cause metabolic acidosis and gastric hypersection. The nurse should recommend a diet that is high in fat and low in carbohydrates, as this can be beneficial in reducing bacteria production. Surgical interventions include stricturoplasty, which there's a picture here. Intestinal lengthening and interposed segments are surgical implant interventions that can be performed to slow down the intestinal movement, reducing bacteria production or to increase the surface area for reabsorption. These surgeries are utilized in children that have been on TPN long-term and have had severe complications. The prognosis for infants and children with short bowel syndrome has a mortality rate of about 30% within the 5 years of the diagnosis. The mortality rates are increased in those with extreme loss of small intestines. The shorter they are, the higher the risk for mortality. And those with ileocecal valve, without ileocecal valve, also have a higher risk for mortality. The family will need support services during this time. Here are my references.